Hello, I'm Matthew Beavers. I'm the Associate Director for Education in the Neurosciences ICU at Brigham Women's Hospital and an Assistant Professor of Neurology at Harvard Medical School. And I'll be discussing the management of hemorrhagic stroke. A couple disclosures. I have a grant from NINDS to study intraparenchymal hemorrhage, and I'm the site PI at Brigham Women's Hospital for the Saturn trial of statin use after intracerebral hemorrhage. I will be mentioning the Saturn trial in the talk today. So I'm defining here hemorrhagic stroke as spontaneous primary intraparenchymal hemorrhage. So we're not covering secondary structural causes of hemorrhage like aneurysm rupture, trauma, or AVM or other mass. So stroke is overall the fifth leading cause of death in the US with an incidence of about 800,000 annually. Only about 10% of this total is hemorrhagic. However, while overall stroke mortality has declined, mortality from intraparenchymal hemorrhage is disproportionately high at 26 to 48%, and these rates have remained steady. So this is an overview we'll be discussing today from the initial evaluation to the initial medical management, surgical management, and then finally prevention of hemorrhagic stroke. So we'll begin with questions about the neurologic exam and laboratory values. So when taking a history, you want to look into any history of cerebrovascular disease, particularly hypertension and diabetes, as these will put you at risk for hemorrhage. Things like dementia or cognitive impairment can be early signs of cerebral amyloid, which we'll discuss later. Then, of course, histories of recent trauma, recent surgery, alcohol, drug use, and other conditions like liver disease and cancer, which could influence coagulopathy. Of course, in any patient, you want a neurologic examination to identify any focal signs that could suggest an underlying bleed or stroke. Blood pressure and heart rate are important vital signs, and then laboratory data really goes at understanding coagulopathy. So things like CBC, coag studies, as well as other corollary factors like blood glucose, troponin, and toxicology screens. The key to diagnosing acute intracerebral hemorrhage, however, is acute neuroimaging. While the exam can give you a sense of a lesion, you're not going to know it's blood until you look at it. And so the basis of this imaging is a non-contrast head CT. This is highly sensitive for intracranial blood. You should obtain a scan on presentation and then a repeat scan at 6 hours later. This is to look for any signs of early hematoma expansion. Further scans are then based on imaging stability. If there's no change at 6 hours, you can sort of space scans out. If there is a change at 6 hours, you want to get a quick follow-up. And then, of course, any change in clinical exam. On one of these initial scans, it's important to obtain CT angiography as well. This really is important for understanding the etiology of the hemorrhage. And so here on the right, we see an example of what we're not talking about today. So this is a massive AVM. All of these sort of tortuous vessels in the left hemisphere are an underlying mass lesion that would explain a hemorrhage in this patient. However, even if you don't find sort of an underlying lesion, delayed sequences in CTA can have you a sense of hematoma expansion. This is the so-called spot sign. And so this is based on two prospective studies in patients with intracranial hemorrhage and had an acute CTA done. The spot sign is shown here by the large green arrow on the left. And so it's this little dot of contrast extravasation within the hemorrhage bed. And this was shown in these studies to be associated with increased risk of hematoma expansion. So having identified a focal neurologic sign and then determined that it's hemorrhage based on imaging, there are a few grading scales that it's important to know when talking about hemorrhage. So the first of these is the ICH score. And so this was developed as a measure of severity of ICH, and mortality increases with score. So it's based on a few things. First, the Glasgow Coma Scale with sort of severe, moderate, and then mild Glasgow Coma Scale severity, giving you decreasing amounts of points. The ICH volume with a cutoff at 30 cc's. The presence or absence of intraventricular hemorrhage, and then the location with more severity being associated with infratentorial or those lesions in the brainstem or cerebellum. And then higher age. The second score was really designed here rather than a descriptor of severity, but as a better predictor of functional independence. And so in this case, higher scores are better. So this is the FUNC score. It's based again on volume, age, location, but it breaks it out a little bit more here into lobar bleeds, so those out in the cortex versus deep structures like the basal ganglia or thalamus, or those in the posterior fossa, cerebellum, brainstem. GCS score and the presence of cognitive impairment. And so this actually does show a good correlation with outcome. And you can see that higher scores are associated with a higher percentage of patients that are functionally independent at 90 days. This is true both looking at the entire cohort or only in those that survived the initial injury. And so a couple important comments on the use of these scales. ICH score is not really intended as a predictor of mortality. It's used only for research and only to communicate degree of ICH severity, so similar to the NIH stroke scale, which you may be familiar with. The FUNC score, on the other hand, was really designed to predict functional outcome based on the Glasgow Outcome Scale. And so this really is more of a predictive tool. However, in any of these things, it's important to be aware of the problem of the self-fulfilling prophecy. That is, if patients come in and we tell them, oh, this looks really bad, you have a high ICH score, oftentimes care is withdrawn. And so you want to be careful in prognosticating and use these to sort of guide your understanding of when looking at the whole picture of the patient. All right, and then finally, the differential diagnosis. So once we've established that we have a bleed, we're looking at sort of primary versus secondary. So again, today we're primarily talking about primary IPH. So the most common of these, occurring about 2/3 of the time, is hypertensive IPH or small vessel disease. And this image here shows that. So these are the type of bleeds you see in the sort of deep subcortical structures, basal ganglia, thalamus being the most common locations. The second main type of primary IPH is cerebral amyloid, and we'll show an image of that next. Secondary IPH is anything caused by another underlying lesion, whether that's an ischemic stroke that converts, an underlying vascular malformation, a ruptured aneurysm, or a tumor. So here we're showing a photo of a patient with cerebral amyloid. And so on the left is the acute CT scan showing the bright hemorrhage. And you can see this is what we call a lobar hemorrhage. And so it's out, in this case, in the parieto-occipital lobe, out in the cortex and subcortical white matter. The right panel shows the susceptibility weighted MRI. And so this is a sequence that's particularly sensitive to blood products and to heme. And so any blood on here is going to appear dark. And so we can see the large dark area corresponding to the bleed we see on the CT, but we also see all these little dots of hemorrhage. And so SWI is very sensitive and you get a blooming artifact. So any small amount of blood that's not visible on CT will bloom and appear larger in SWI. And so what this shows is evidence of prior microhemorrhages. So these were probably asymptomatic, but they're instances in which there have been small vessel ruptures causing small bleeds over time. And so this is important because it goes into the diagnosis of cerebral amyloid. Cerebral amyloid is diagnosed based on the Boston criteria. So definite amyloid is based on pathology. So a full postmortem that shows hemorrhage and underlying vasculopathy. Probable plus is a lobar or cortical bleed and shows a biopsy that shows cerebral amyloid. So a buildup of amyloid protein in the vessels. And then of course, no other explaining lesion. Most commonly, we're making diagnoses based on probable or possible CAA. And so probable is just what we saw on the last slide. Either multiple lobar bleeds, or which can include the macrohemorrhage that we saw, and then the multiple microhemorrhages, and then an age greater than 55. However, it's important to note that because CAA is the most common cause of lobar bleed, even a single lobar bleed in a patient over 55 is considered possible CAA, and we consider it to be that until we've proven otherwise. It's important to consider a couple mimics. So subarachnoid hemorrhage or aneurysm rupture can present primarily with IPH. So this is classically an aneurysm at the bifurcation of the MCA. And what you see here is that you get this large intraparenchymal hemorrhage that would mimic a lobar bleed. However, there's a more subtle associated subarachnoid hemorrhage. This highlights the importance of doing CT angiography to look for underlying lesions. A second mimic is a VST or a venous sinus thrombosis. So here on the left, we again see what looks like a lobar bleed. There are a couple giveaways here that this isn't classic amyloid. Unlike the last example, we see this goes all the way out to the bone, all the way out to the skull table, and there's more surrounding edema. And so what this actually is a venous infarct. And so on the right, you see an MR venogram that shows basically a loss of the transverse and sigmoid sinuses on that side, suggesting that there's clot here and the venous back pressure caused the bleed. Again, highlighting the importance for vessel imaging in anyone with an IPH. So this just gives an overview of the timing and modalities of neuroimaging. So anyone where you're suspecting a sudden onset of focal neurologic deficit, where it could be a bleed, non-contrast CT on arrival is the key imaging. If available, a CTA can be done at this point. Once you establish the diagnosis of hemorrhage, a stability scan should be obtained about 6 hours later to make sure we're not having further expansion of hematoma. At this point, if a CTA was not done or if there's concern for venous hemorrhage, a CTA or CTV can be done at this point. And then looking at about 24 hours, you may need additional imaging. So during this first period, you're frequently assessing the patient. Oftentimes these patients are admitted to a neurointensive care unit. They're getting at least 1 hour neuro checks. If there's any change in exam, we're repeating a CT scan. And then around 24 hours or later during the initial admission, you're often doing additional studies to look for etiology. This could be an MRI to look for amyloid. It could be a conventional digital subtraction angiography if there's some concern about an underlying lesion that wasn't picked up on CTA. Sometimes, if it's not clear CAA, we're worried about an underlying mass to then repeat an MRI months down the road as an outpatient to look and see if perhaps there was an underlying tumor or something else that we didn't pick up on initial imaging. All right, so having diagnosed the hemorrhage, we now spend our time on really the key components of medical management. So the most important thing to do first is reverse any possible coagulopathy. And so this is the entire coagulation cascade, which often we haven't thought about much since medical school, but I put it here just to highlight all the places in which we interact with this. And so we have Coumadin or warfarin, which is interacting with the vitamin K dependent factors. More commonly now we see patients on the direct factor 10A inhibitors or on the direct thrombin inhibitor dabigatran. In inpatients, they sometimes are on heparin, either as a continuous drip or sometimes outpatients on low molecular weight heparin. And then finally, we have patients who've been given TPA. This, again, is more common in an inpatient setting where someone's been given TPA for another indication, and this is causing coagulopathy. And so we have each of these components in which we're interacting, and we have to think about the specific ways we want to reverse this, because reversing coagulopathy is key to limiting hematoma expansion. So for warfarin, as we said, these are the vitamin K dependent factors, but just giving vitamin K is too slow. You want to really replete the factors before just stopping the effects of warfarin. And so classically, this is done with fresh frozen plasma, and this is still very widely available. More recently, we've been using prothrombin complex concentrates, so multiple factors, basically direct concentrated factors to replace. There's evidence that these reverse INR more quickly. And so in an open label trial of about 200 patients, only a few of whom had ICH, patients were more rapidly achieved their INR. So more of them got there within a normal INR within 30 minutes. More recently, there was a second study looking at outcome, and this actually shows that the use of 4-factor PCC was associated with better outcome. And so these patients tended to have better modified Rankin scales, that's MRS 0 to 3, so a lower level of disability, given PCC or PCC and fresh frozen plasma than just frozen plasma alone. So this is what we now use at my institution and most institutions for reversing warfarin. Heparin, so the reversal agent here is protamine sulfate. This is given in a dose based on the amount of heparin given in the prior 4 hours. It's less effective, but can be used for low molecular weight heparin, in which dosing is based on the timing of the last dose of low molecular weight heparin. The direct 10A inhibitors can now be reversed with a 10A decoy protein called andexanet alpha. A number of studies have supported its use. First, in healthy volunteers, where it was shown to very effectively reduce the 10A activity induced by these direct oral anticoagulants and fully restore thrombin generation. A study with major bleeding found that there was a similar reduction in 10A activity and good or excellent hemostasis, about 82%. And then more recently, a subset of this trial really was looked at just those patients with intracranial hemorrhage, where again, it was shown to be quite effective at reducing anti-10A and achieving hemostasis, that is blocking hematoma expansion. A trial of the effect on outcome is ongoing. And so this really is the primary choice if someone comes in on a direct 10A inhibitor to rapidly reverse coagulopathy when they present with hemorrhage. Dabigatran, the direct thrombin inhibitor, can remove with either urgent hemodialysis or more commonly now, there's a monoclonal antibody that targets this and has been quite effective at reversing that. Finally, TPA. Here, the strategy is really focused on replacement of fibrinogen. So as you can see from the diagram here, the effect of TPA is ultimately to break down fibrinogen and ultimately activate plasmin so that you're not forming clots. And so cryoprecipitate is the classic strategy here, again, wildly available and effective. However, we have really moved towards using concentrated recombinant fibrinogen, which is very effective and may have a more favorable safety profile. Finally, one comment on platelets. We know that prior antiplatelet use is associated with greater in-hospital mortality after ICH, and there doesn't seem to be any effect of transfusion on mortality. A few years back, the PATCH trial was conducted to look at platelet transfusion versus standard care, so a little fewer than 200 patients. And this actually found a greater odds of death are dependent in 3 months in those who received the transfusion for a variety of reasons. There were complications of transfusion here and other reasons why this may have happened. And so for that reason, we don't routinely give platelets in patients who have ICH. It's important to note, however, that this does not apply to surgical candidates. And so those that are going to the OR weren't studied in this trial, and so there may still be a role for giving platelets in that situation. So what about patients without coagulopathy? So some trials have been done to look at doing things like TXA, tranexamic acid, recombinant factor 7A for patients. In general, these have not been effective. And so as it is right now, if a patient doesn't have an underlying coagulopathy, they weren't taking anticoagulant, there's no specific intervention. All right, next, the next sort of main key goal of management here is blood pressure control. And so we know that intraparenchymal hemorrhage is associated with underlying hypertension, and higher blood pressure is related to hematoma expansion and worsened outcome. And so for this reason, there have been a number of studies looking at the effect of blood pressure management on hematoma growth and outcome after ICH. So the first two studies were done in 2010. These were INTERACT and ATAC. They had slightly different designs. INTERACT was less than 140 versus less than 180 systolic. ATAC split this up into 3 groups. In INTERACT, they weren't able to really achieve their targets, but the intensive treatment group did have a lower mean, and they did see less hematoma growth. In ATAC, they did a better job achieving their goals, except the very sort of intense group, and they found no difference in rate of adverse events. So from this, we sort of took away lowering BP is safe, and maybe there's a benefit. So these were followed up with larger studies, INTERACT-2 with almost 3,000 patients and ATAC-2 with 1,000 patients, looking at similar blood pressure targets. So less than 140 versus less than 180 in both trials. And looking at outcome again on the modified Rankin scale. So very mild disability versus severe disability. In INTERACT-2, their primary outcome was splitting the MRS scale into 2, and they saw no difference. However, if they looked at shift across the whole scale, there was a significant improvement in outcomes. In ATAC-2, they found no effect of the treatment group. However, it's important to note that in this trial, even in the intensive group had relatively lower blood pressures, whereas in the mild group had relatively lower blood pressures. The intensive group was very, very low. And as a result, they found more renal complications with intensive BP lowering. And so the interpretation from this is that there's a potential for outcome improvement in those patients where lowering the blood pressure is safe. And so based on this, we still generally follow the American Heart Association, American Stroke Association guidelines from 2015, noting that this was prior to ATAC-2, and that we tend to lower the target blood pressure to 100 to 140. A meta-analysis of these prior trials showed that there was an association with outcome. And so really in my current clinical practice, I try to rapidly reduce blood pressure to less than 140. If patients show evidence of renal injury, or if they have some chronic kidney disease and have sort of chronic very high blood pressure, I will sometimes liberal the goal to less than 160 or less than 180 within the first 24 hours. Choice of agents important here. Really, you want IV drugs initially. So either pushes of labetalol or hydralazine or continuous nicardipine. You want to avoid nitroprusside due to the effect on ICP. And then chronic agents, you really want to get these patients over to oral agents as soon as possible. And so these are beta blockers, ACE inhibitors as the first line agents. All right, quick note on management of intracranial pressure. So when you have a hemorrhage, there's an increased sort of mass effect from the hemorrhage in the brain, and this can cause elevated intracranial pressure. People who have traumatic hemorrhage, the guidelines suggest ICP monitoring if the GCS is low, less than 8, so patients who are in coma. We don't typically monitor patients with spontaneous intracranial hemorrhage unless they have a very, very poor exam. If they do have, for example, blood in the ventricles and that are developing hydrocephalus, we will drain that. There may be situations in which you want to consider calling the surgeons to take the hematoma out. If, for example, the patient is in coma, very severe exam, large hemorrhage causing a lot of mass effect. But the mainstay of managing ICP is hyperosmolar therapy. And while the details sort of are beyond the scope here, we do this with doses of either mannitol or 23% hypertonic saline, either singly or alternating. Most important, should note that there's no role for steroids in ICH. There actually have been some studies suggesting an increased mortality with the use of steroids. And so as a result, current AHA guidelines recommend against their use. And then finally, other supportive care. So these are sort of standard. These patients are typically in the ICU. They're typically quite sick. And so we do standard ICU goals. We avoid hyper and hypoglycemia. We avoid fever, although there's no established role for hypothermia. Patients have obviously neurologic deficits and they're at high risk for aspiration. So we have them sit up, they had a bed at 30 degrees. We do swallow screening before they take anything PO, really try to avoid these complications. Seizures is a question that frequently comes up because there is a high incidence of both clinical and electrographic seizures after ICH. If you see clinical seizures, or if you have a patient whose exam is worse than might be expected, you should suspect seizures and look at them with continuous EEG. However, we don't routinely give prophylaxis for patients that come in with primary cerebral hemorrhage, because there's been no shown impact on mortality or functional outcome by giving early treatment with anti-seizure drugs. All right, so medical management is the bulk of how we manage ICH initially. However, there are some situations in which there is a role for surgery. Begin by discussing the surgical management of intraventricular hemorrhage. And so this can happen either primarily or as an extension of an intraparenchymal bleed. And so that's what we see on the right here. We see a bleed in the thalamus that is sort of broken out into the ventricle and is filling up that right lateral ventricle. If you see only IVH, it's very important to rule out an aneurysm, as that's a common cause. However, regardless, if a patient has an intraparenchymal hemorrhage with intraventricular hemorrhage, it's independently associated with poor outcome. And so the management of this depends on the presence of or the risk for hydrocephalus. So blood in the ventricle can block the reabsorption of CSF, and you can have accumulation of CSF and hydrocephalus causing elevated ICP and decline in exam. So reasons to place an extraventricular drain. So basically a bedside drain placed into the ventricle to release CSF. So any change in exam, if the patient's sleepy, if they have restricted up gaze, you want to think about relieving that pressure. If the vesicles are casted, so that is if they're completely full of blood, and so we know that we need to get some of that blood out in order to avoid hydrocephalus. And then finally, if they've obstructed the third or fourth ventricle, there's a reason to place an EVD. There have been a few trials of going beyond just placing a drain and actually putting TPA into the ventricle to break this up. And so these are the CLEAR IVH and then CLEAR 3 studies. And so this placed in an extraventricular drain into the lateral ventricle and then instilled TPA about every 8 hours versus saline. The initial study showed sort of no difference in inflammation, which was a concern, or in infection rates, and somewhat faster clot resolution, but wasn't really powered for outcome. CLEAR 3, done more recently, had 500 patients, similar protocol. Again, no differences in bleeding, no differences in inflammation. However, there was also no difference in the rate of good outcome at 30 days. There was a lower mortality about 6 months out, but at the cost of patients surviving with more severe disability. However, when the TPA was effective at removing the clot, so sort of small intraparenchymal component, a lot of blood in the ventricle, and the ventricle cleared, patients did do better. And so for this reason, it's thought to be safe. It does clear the blood faster. And so there may be a role in select patients. Similar studies have been done doing surgical removal in which they use an endoscope to remove blood. And there is also some evidence for an outcome benefit here. Finally, hematoma evacuation. And so is there ever a role for sort of taking out the blood? And so I think there are certain situations in which the patient has a large amount of bleed and they're sort of going to imminently die if you don't take it out, in which case we send those patients to surgery. What is less well understood are the patients that may have a smaller bleed. And so there have been 2 studies looking at this, STITCH and STITCH 2, in which patients were randomized to early surgery versus medical management alone. So the first study found no difference in mortality or functional outcome. There was a subgroup who were in coma, so GCS less than 8, in which they actually did worse with surgery. There was also a subgroup that had very superficial clot, so clot very close to the surface, that did better. And so based on this, a second study was done in 2017, looking just at these superficial clots, so less than 1 centimeter from the surface. They found a non-significant increase in survival. And then if they had a subgroup in which the sort of a priori prediction was these people would do badly, they seem to do better. And so there are some issues with these trials. One, I put randomized in quotes in the STITCH trial because it excluded any patient in which the surgeons felt like, oh, this person will definitely do better if they have surgery, right? And so it doesn't really, there isn't really equipoise, it isn't really looking to everyone. And so really this is an individual decision at this point. It should be noted this doesn't apply to those infratentorial, so the cerebellar and brainstem hemorrhages. So these are the ones that you remember way back when we were talking about the rating scales. These are the ones that tend to do worse. And it's because these patients are at high risk for compression of the brainstem, development of hydrocephalus. And so you really need to be aggressive about treating these. And so the first line is still hyperosmolar therapy to shrink the brain, treat any edema. However, if you have a hemorrhage in the cerebellum, like we see here on the right, and it's pushing on the fourth ventricle and the patient's developing hydrocephalus, the blood should come out. Similarly, if the lesion's bigger than about 4 centimeters across and the patient's sleepy, there's good evidence that that patient should, that hematoma should probably come out. Finally, a comment on minimally invasive surgery. So there have been a few studies on trying to basically reduce the morbidity of the procedure to see if that would help with outcome. So the first of these, so the two of these were MISTI and ICES, which were conducted around the same time. And this basically was either for ICES an endoscopic clot evaluation, or for MISTI, they placed a catheter under stereotactic guidance and put in TPA. They were able to reduce clot volume. There was some increase in asymptomatic bleeding, but there was a suggestion of benefit. And so based on these, a phase 3 trial was done looking at a larger number of patients. There was no effect on the primary outcome, so low disability at a year. However, there was lower mortality with the intervention, and those where the clot came out did have a better outcome. And so what I take away from this is that probably it's a question of technique. When we get to a place where we can do this with minimal morbidity from the procedure and good removal of the clot, probably we will end up showing a benefit. And so there are several ongoing trials. The ENRICH trial is one of them, where basically it's a minimally invasive approach using an exoscope. Others use endoscopes to basically try to remove the clot and minimize any morbidity from the procedure. And recruitment for these trials is ongoing. So in the last few minutes, I want to make a couple comments on prevention of recurrence. And so while most of the management for ICH happens initially and sort of limiting further injury, and then there's a sort of a big phase of rehabilitation, which is well beyond the scope of this lecture. I think a lot of what we also want to think about is how do we keep this from happening again? And so a lot of it is sort of modifying those risk factors we can. So managing blood pressure. Obviously, nothing we can do about age, nothing we can do about sort of location or CAA, but these are the ones that sort of highest risk. We want to get the blood pressure down, so chronically less than 130/80, like general guidelines. Things like smoking cessation, weight loss, treatment of sleep apnea, which are often comorbidities in these patients, will help reduce their blood pressure and reduce their risk. There is an ongoing question about statins. So in the SPARKLE trial, which was the trial that sort of established the use of statins after stroke, there was a note that there was a small association with increased hemorrhage in those patients on high-dose statin. It's a little unclear, in fact, it's very unclear whether the benefit of statin outweighs the risk. And so a trial of continuation versus discontinuation is ongoing, the Saturn trial. And so I'm involved in this trial here at Brigham, and it'll be a few years before we have that answer. Another big question that comes up is, when do you reinitiate anticoagulation? So obviously being on anticoagulation is a risk factor, but people are on it for a reason. We know that the risk of rebleeding is higher than the risk of thromboembolism early, and it reverses later. And this seems to happen around 4 weeks. And so typically we wait at least 4 weeks before restarting anticoagulation. This depends on the indication. And so patients with a mechanical valve, where they're at very high risk for clot, we will often sort of put the anticoagulation back on sooner under close supervision. For atrial fibrillation, you could consider antiplatelet alone because there is some efficacy there. Or increasingly, we refer patients who we feel are very high risk for rebleed. So those patients with CAA, for example, that have had multiple lobar bleeds, we often send them for atrial appendage closure to help reduce their risk. There's relatively limited data on the relative safety of the direct oral anticoagulants after ICH. It's typically what we use, but we don't have a ton of data. All right, so that has been an overview of the initial evaluation, medical surgical management of ICH, and then prevention of recurrence. I've placed some key references here, the current guidelines from 2015, Boston criteria for CAA, and then the major trials for surgical intervention and for blood pressure management. Thank you very much for your attention.